Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. Hello and welcome to the March 2026 Pre-Hospital Care Research Forum Education Research Journal Club. The PCRF promotes research literacy to advance the science of EMS educational research and clinical practice. And here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. Thank you to Limmer Education for always sponsoring these podcasts so we can bring you the best of science in medical education. I'm Megan Corey. I'm here with David Page and Dr. Kim McKenna, soon to be joining us, Dr. Bill Toon. And today we're going to be discussing this article published in Academic Emergency Medicine Education and Training. This is an open access article, so you can get it yourself. It is called Simulation-Based Mastery Learning Improves Emergency Medicine Residents' Ability to Perform Emergency Cricothyrotomy. And thank you all for joining us today. We can begin, and we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. And just to remind you that you can, if you miss any parts of our journal clubs or you want to catch past journal clubs, you can find them, this one and others, on our YouTube channel. You can look us up at PCRF at UCLA or just search PCRF Journal Clubs on YouTube, and you'll find both the clinical and the education research monthly recordings. So today we're going to take a look at this study. It's a real short article, so it's something that you can digest even in the middle of your semester. Some of you may be going on spring break if you're an EMS educator, or if you're a continuing education educator, you probably don't get a break. But today we're going to be looking at this study that uses a competency-based education model to develop an emergency medicine resident mastery in the procedural skill of emergency cricothyrotomy. So I picked this article for a few reasons, and I'm really glad Kim and Dave can join us for this, because there's some experience here on developing these kind of mastery learning, or I guess we would call them checklist standard settings for procedural skills when it comes to EMS. So I chose this because emergency cricothyrotomy is also a critical skill infrequently performed under extreme high-stakes situations for advanced level EMS providers as well, not just emergency medicine residents. So it's directly applicable to our advanced level providers in EMS. The second reason I chose this is because the research involved competency-based education, and that is definitely something that we've been talking about a lot in education, a challenging subject because we've been using the time-honored tradition of time-based education, where we hold time a constant and we vary competency, rather than mastery, holding everyone to competency and varying the time to actually achieving that, which is a challenge because of the way that education is set up. But there's key principles here, like evidence-based education practices that support a mastery learning model, that are in this article with some great references. Things like deliberate practice and standard setting, using something called a mastery Angoff method to develop a minimum passing standard, simulation-based learning and simulation-based mastery learning. These are all kind of best practices, evidence-based practices that we've seen and we've talked about here. So it's all kind of in this article. The research also did an evaluation. So last month we looked at a study that looked at an evaluation of an educational intervention. And this does the same thing, but only looks at sort of the early outcomes. That doesn't make a difference in performance and in satisfaction and confidence. So when you look at this, research evaluated a baseline performance, had a post-test and retention testing on a procedural skill. And last month we talked to authors about their development of a similar thing, but they used the Kirkpatrick method to evaluate the effectiveness of their educational intervention. They looked at translation levels, and we call it, education is a translational science, or can be education research. We translate it to, we do the educational intervention. Does that translate to better learning outcomes in the simulation lab in this case? And then does that translate into some retention outcomes? But then the next translation level, does it translate into the clinical performance outcomes we'd like to see? And then the next level of translation is, does it translate into better patient outcomes? And this group that did this research, if you look into it, you'll notice they're from Northwestern, and Northwestern University has the Feynman Medical School and the simulation-based mastery learning research area. They did a landmark study on central venous catheter insertion in residents in the ICU after noticing that there were an unacceptable number of infections from central venous catheter insertion. And so they used this translational science to develop a simulation-based mastery learning curriculum on central venous catheter insertion that translated into better educational outcomes, and then measured it out into patient outcomes, fewer infections in patients in the ICU, and then took it all the way out to a kind of a fourth level, which was return on investment. How much money did they save from not having these infections? And by walking it out from this educational intervention all the way out to that return on investment, that's taking that, that simulation-based mastery learning all the way out to the ultimate outcome. So this is the same group that actually was part of this landmark study. You might mention one of the authors' names, or is actually not one of the authors, but one of the major researchers is Dr. William McGahey, who was a PhD in educational science, and he has been a major leader in some of these studies. And also, if you look at the ACLS, the American Heart Association outcomes or updates, you'll see that there's a section on education. He is one of the leaders of some of the simulation-based mastery learning curricula that come out of the ACLS and resuscitation science. So those are the reasons I actually picked this. And I wanted to go through the methods, and then I want to talk to Kim and Dave a little bit about standard setting, because that was a really important part of this research. So essentially what they wanted to do was to develop a simulation-based mastery learning curriculum that they would teach emergency medicine residents emergency cricothyrotomy, and then compare those early outcomes, pre the baseline testing, post-training scores, and then retention of mastery. Again, using a mastery learning, we'll go through that. You'll see that a nice little figure that they put into this article that describes the paradigm. And then, of course, they get student feedback and confidence as well. That's usually part of those early translation stages. So this is that figure that shows the mastery learning paradigm, the baseline testing, and then evaluation using a checklist, deliberate practice for those who did not achieve mastery on the checklist, deliberate practice, post-testing, did mastery get achieved? If they didn't, they go back into this cycle of deliberate practice, post-testing, and mastery achieved. And then finally, retention testing. So this is just a basic figure, but there's a lot of things that went into the actual development of the checklist before ever getting to the baseline testing. And that's why I want to bring in Kim and Dave, because they go through this whole process of developing a checklist using a blinded, first of all, they had a previously published checklist for emergency cricothyrotomy that they published and that had good inter-rater reliability. So they could have just used that. But what they did was they took that And they used standard setting with an expert panel that was blinded from one another. None of them were part of the creators of the original checklist. They were all out, working trauma surgeons and whatever. And they had them go item by item through this 27 item checklist. And they used what's called the Mastery Angoff approach. And by the way, Comprehensive Healthcare Simulation is a book, Mastery Learning in the Health Professions Education, that actually has a lot of information about what a Mastery Angoff and other methods of standard setting are. And that's what they used to establish what's the minimum passing standard. And they came up with 26 out of 27 items on the checklist. So the reason I want to ask you guys is because Dave, I believe you were part of that National Registry portfolio development, the portfolio that I think everyone has kind of forgotten or put on the shelf that really still has a lot of great information in it. I really think that we kind of missed the boat on that one, that we put it away and forgot that there's a lot of really good information in the text of that leading to those sheets.
Yeah, I wish it was still very much in you. I think it's in use. It's just that new instructors may not even know it even existed. The 2015 final version of the checklists that were created for that. But in it, there's a lot of prose about just how to conduct psychomotor education in general, and I think the new guidelines that came out on simulation, that the National Registry collaborated with COA-MSP and used the Society for Simulation in Healthcare (SSH) dictionary was really a great addition to that. But the portfolio lives on, I think, in those of us who still use it. I do think so. These are actually critical terms, and when people toss around mastery, I immediately just ruffle, especially because I have years of Angoff standard setting that is minimum passing standard, which this article refers to, the MPS, the minimum passing standard. And so we ask raters, whether it's a multiple choice question or an element in a checklist, just how, if you will, critical or essential it is that a candidate really should know that. And it's a blend of should and will, what is minimum. So if you ask, new EMT whether they know about tetralogy of Fallot, maybe that's like a very few are going to know that, and it's not really as essential. But open the airway with a head tilt chin lift and give a breath. That would be like everybody should know that. That's an essential. 100% of the population that is going to become an EMT should know that. When you get into the mastery Angoff approach, you start to begin a fairly subjective process in which the raters are now going to perform the same judgment they were about what's absolutely minimum, but now you're asking them to interpret the term mastery.
Mm-hmm.
And I actually, if you think back to Bloom's taxonomy and sort of a progression or a spectrum or a process by which cognition develops and improves and reaches nirvana, if you will, the nirvana of the Bloom's taxonomy applied to psychomotor, which was done by Dr. Dave, actually is the person who adapted it in 1970. You think about observing, imitating, practicing, and naturalizing, and the top, and maybe even adapting. So the naturalization of a motion or an event, such as we get into a car and we now just stick in the key, or not stick in the key if you don't have a key anymore. You hit the button and you start to drive. you don't think about all those steps anymore because they're naturalized, and you
Hmm.
immediately put your seatbelt on, look in the side view mirror. These are no longer conscious steps. So I think that naturalization is maybe where I would put the mastery, because I take the term mastery very seriously. I think of it as now the master may not even be aware of the fact that there's steps anymore. They're just doing the thing, and they happen to do it so fluently that it's just the fluidity of the motion, and activity becomes a part of them, right?
Well,
So,
that's expertise then, right? I mean, because
mhm,
there a
mhm,
difference between and
mhm.
in this case, I think when you this group that has developed the curriculum and everything, I think they're referring to mastery more as the achievement of what they've defined as competency, which is 26
Yeah,
out of 27,
yeah.
not
That I don't
not
like that about this
expertise.
article. That
Well,
I think that
that's the general principle though of mastery learning is are they, is mastery really what we're saying is competency? And
right.
and what you're talking about is from novice to expert, where you go novice,
Hmm.
advanced, beginner,
Hmm.
competent,
Hmm.
proficient, and expertise is
Hmm.
the highest one. So I
Yeah, I
think when we
don't
hear
love
mastery,
the
we think expertise, right?
right, right.
Yeah.
And minimum competency to me, mixing that with the concept of mastery, just I didn't like that part of this particular piece. I also just want to put a disclaimer out there before we get too deep into this
Yeah.
into this webinar that cricothyrotomy is no longer recommended as an airway procedure in PHTLS based on evidence that says, we really, if we're going to do a surgical airway, we should do a surgical airway, not cricothyrotomy.
You
So
mean
maybe
needle cricothyrotomy? Are you
needle
talking about?
cricothyrotomy,
Yeah.
correct? Yeah. So thank you for the correction. Just so in case
Hmm.
we don't want to get letters about, what are you doing promoting this thing? So already, I think the choice of the procedure was kind of an interesting thing. These rare procedures, absolutely. So anyway, yeah,
Yeah,
yeah.
that it's a good point because that's something that I have as kind of a note here to myself is that what when you're looking at something that is a rare, it would be very hard to do translational science on this because you don't have enough patients at the end to say, does it make a difference? But does that mean that we don't do, this is the kind of time honored argue, the discussion on these procedures where you're not going to get a huge N, but
Yeah,
is
high
it a,
acuity, low
yes,
frequency. We need to
very
know
low
how to do these
frequency.
things.
Yeah.
No
Do we
doubt.
need to know?
Mhm.
Is there an alternative with all the new airway things, the bougies and the videos and and just the, MacGyver gestalt of
Mhm.
understanding the anatomy of an airway? Is it important? That kind of thing. So,
Mhm.
Kim,
Mhm.
did you have something to add to this?
No, I love this. I love this because, I think what I took away from it is, in my mind, their definition of mastery was doing it again and again and again until you can't do it wrong. Like it becomes so automatic, which is kind of like naturalization. But naturalization really only happens after you do it again and again and again in a real life situation,
Multiple
having
settings.
done
Yeah.
it in many contexts. So I would
Mhm.
argue that nobody
Mhm.
ever becomes naturalized at surgical or surgical
Yeah, surgical
cricothyrotomy.
cricothyromy is yes, I
I mean,
agree.
hopefully not. Like,
Yes. Yeah.
hopefully not.
Well,
Uh,
again, and I think that's the distinction they make between they actually have they had a podcast when this book first came out, the Comprehensive Healthcare Simulation, and they talked about mastery. I remember being very confused, going, "Wow, I always thought mastery," and then I was thinking, I'm confusing from novice to expert. The proficiency and expertise are after competency, and mastery here they're talking about achieving, in a single test over and over again, so everyone gets the score, the 100%. It's like giving someone a test, a written test. Like to Dave's point, you can do this with a multiple choice test and say and have them okay, I want you to repeat it with feedback and repeat it with feedback and repeat it. And then, take it again 3 months from now and see if you can keep that score of 10 out of 10. We want you to get 10 out of 10 on this critical airway test, even if it's a written test. And that would be mastery. That doesn't mean you're an expert in airway management. It means you mastered that test. So that's what I think there.
So here, I think, I mean, what Kim said is just so critical. Like we think of, think of it as we're talking IVs. Kim Grubbs did this from Johnson County Community College in the early years of the COA, and I think that article was a seminal article on the issue, looking at the development of IV skills. So, do you want someone who can start an IV, but only can do it under lit circumstances with a beautiful vein with a tiny needle, and only do it when the patient is immobile in a hospital bed? And we in EMS want people who can naturalize and adapt, because they need to be able to do the IV in a moving ambulance with skin that is maybe not necessarily uniformly the same. We need the ability to recognize low light, well lit situations, and outside, inside. So how many times do we have this deliberate practice event before we're asking the novice to adapt the skill? And then how many times do they have to prove that they can do the skill in alternative contexts before you say they've reached competence? Competence, not necessarily that they could put a butterfly needle into a tiny little vein in a scalp of an infant, but they could at least get a 20 gauge into the arm of most patients of most years. So I think that it's so sweeping to say in this particularly high acuity, low frequency event, you're going to get enough context to be able to think, wow, I can do this. In combat, as an example, they did an engineering study on how during combat situations could an engineer reassemble a generator that had 6 different steps to it. And my mistake. 20 steps. They had to do it 6 times with battle-like conditions, and then be able to reproduce it when your adrenaline is just taking over, and you're trying to deal with noise or distraction or potential danger to yourself. These are trained engineers who could already assemble this generator, and now they're doing it under pressure, and they had to repeat that 6 times. I think when you think of like musicians who are playing an entire movement, right, and they have to repeat it until their fingers on a piano or on the strings of a guitar, they can get to the point where it's fluid, and that means stopping, restarting when you find errors. I find the oversimplification of the concepts of minimal competency in this article to be problematic. They dealt with procedural task trainers.
Yeah.
But
again, I think it's semantics. I think we're focusing in on, if we use the word competency, achieving competency, I think everyone will be fine with it. They're not saying the word expertise here, and they're certainly not creating experts. But I will argue too that expert, and I say this to my students all the time, again, the same examples, athletes and musicians. That's been studied over and over again. It may look real easy to work alongside or play alongside Michael Jordan, but the hours of this level, deliberate practice, mental practice, and achieving his little competencies in how to square up and shoot and get those things over and over again, the work that went into it was not, somebody who just kind of came, oh, quote unquote natural. There's a couple really good books on how there is no such thing as a natural. And that's what kills kids' confidence when they get to a certain level, is they've been told they're a natural and not realize there's a lot of work that goes into and deliberate practice.
It does bring, this discussion just brings home even if you take it back to EMT, for example, applying a tourniquet. Some programs think, okay, well, we can just teach this in a lab, sign everybody off, and we don't need to practice it again. That's not how you achieve that level of competence that they need to be able to, because you need to get them up to articulation. Can they do it in the context of at least a simulation? They're probably not going to see it in clinical, but so many.
A great example, because
Yeah.
like the cricothyrotomy example, and I do a whole talk on this at conferences. There's the theory of it all, and then there's when blood starts to spurt places.
Yes.
And so things get slippery. Applying a tourniquet in a slippery arm with, when it's just spurting is a whole different game. And the cricothyrotomy is the same. And so, sim man spurting blood while you're, trying to, or even just having a pool of blood and having to deal with skin that's just wet. And to me, that competence of achieving a checklist. First of all, I really am a big proponent of checklists and career resource management, and I think this is great. So I really applaud them for doing this research. At the same time, I do wish that in their methods they had been a bit more realistic, a bit more. It's not just about the steps. This was too focused for me on the steps and less on competency.
You raised something, and you raised something that's great. There's in the book that I was mentioning too, there's a whole section on the different ways of standard setting, and one of the ways you just mentioned earlier, and I know I'm promoting a product, but I'm just saying there's different places like FISDAP has. If you do happen to use a product like FISDAP, or and I'm not sure Platinum does it or other ones do it, but they have sessions where you can practice test item development using a traditional Angoff method, where you're picking apart each and you're doing what Dave was talking about before. It's great practice, and actually you can do the same with a checklist, but they talk about different ways of doing that. So there's that traditional method. There's a method where a HOFC, where you can look at an entire test and you have your experts say, what are the passing standards for the minimally prepared student. Mastery Angoff is asked not about the minimally prepared or the borderline prepared student. They're asking about the well-prepared to succeed student. What percentage of the well-prepared student? Then there's another one called the patient safety method, which I think is interesting. And that one determines, to your point, Dave, which of these steps is actually critical and which one is less critical. It's important, but it's not as critical. And that's important because some of them are more important than others. And 26 out of 27 is what they determined on these. But let's look at the steps and say, really, do you have to do that one step? If you miss that one step, is that really going to be a critical fail, below quote unquote mastery? So that I really like that idea.
So important too. Right now, we've gone to I think in EMS, it is the responsibility and a very serious and super important responsibility, if not critical, of the educator to set this standard, because we do not have a national psychomotor exam anymore. So we need the educator to understand, what can we get interrater reliability off of two different observers watching, or multiple, watching the same event and saying that was done. And when you start to put emphasis on every step, the beauty of the psychomotor, they were teaching checklists instead of testing checklists, and they had 50 steps. So the learner is saying, oh, I have to first go in and swab to get an aseptic technique to make sure that I can then do the procedure. In the middle of a cricothyrotomy, one would argue aseptic technique maybe not the most critical element of this. So,
Or possible.
Yes.
Or
you
possible.
struggle to go, well, how's that a 26 out of 27 items on the checklist? Depending on what that checklist is, you may not achieve inter-rater reliability, which is great that they actually, did achieve inter-rater reliability. But for educators listening out there, beware of what it is that you decide is
That's right.
a testing element and what is provable or observable behavior. And so entrusted procedures that we know physicians and other highly trained individuals need to be able to do independently. We need to really just go back to the minimum competency required, and you can't be faulting people for the way they tied a knot unless that knot is so critical that it's in the middle of a surgery and it might cause somebody to die if they do it wrong. How you secure the tube that you placed in the surgical airway, that may not be the most critical piece.
Yeah. The Checklist Manifesto is another book we bring up. That's a very easy to read, fun, good book by Atul Gawande. Gets you really thinking about checklists. If you're a new skills instructor, you're taking maybe the NEMC skills instructor course, or you're taking this level, deep thought has to go into skills checklists. And what level, like you mentioned, there's differences between the novice, the person who's coming in who's never touched an IV, never touched any of these skills, a tourniquet, and the person who's in the second semester, expectations have risen. They're at a different level. The checklist itself and the expectations should change too. You don't want to untwist the IV tubing for somebody who's already started 100 IVs on patients to be a critical fail on a checklist.
So important. And I would think, I'm waiting for Bill to jump in. I'm going to just bait him a little bit because, when you're doing simulation training with experts who are already in the field and continuing education, as Bill did, and you bring it to a level of, now they're practicing clinicians who will do this procedure at the drop of a hat. And like the FAA and the aviation industry, you need to not rely on memory to go, oh, right, that's the way you land an airplane in the water. Like, I think I remember the angle that plane is supposed to be at. So the fact that the culture should be a culture of checklists that are understandable under extreme pressure. So you cannot be looking at a checklist or a process that is 26 items deep and in the middle of a moment where you need to cut somebody's neck open. So your first 3 steps in the procedure need to be so precise and worded in such a way that everyone understands, right, that's what that means. And I think aviation has done that. They've proven that actually going back to the checklist was safer and more reliably successful than trying to by memory recall the procedure, even with fighter pilots and UPS pilots and randomizing who got what. The moment at which you turn back to the checklist is actually essential.
Oh,
I knew I could get Bill to say something.
Let's go, Bill.
Speak, Bill, speak.
I loved everything that's been discussed, but and this is not a criticism of anyone here on the podcast or anyone, but we've been having this discussion for the last 25 or 30 years, and the movement has been at a glacial pace. And this gets much of what's been talked about here is the critical component is the EMS educator. And the EMS educator doesn't have the necessary skills, not all of them, but I think a vast majority don't have the necessary skills to be thinking at this level and working at this level. Because again, EMS education is done on the cheap. The least amount of FTEs are assigned to it. They have a small budget, but yet they're expected to turn out a great deal of people compared to some other health professions. It's just
Well, and to
it's
your
just
point,
disconcerting.
every flight instructor, a brand new flight instructor is not responsible for creating an ergonomically correct checklist that all the FAA uses in order to land a plane in water. So I do think that you need experts who can look at these things and go, okay, at least for 33 residents in this study, we could achieve some level of reliability, right? Just reliability that they will be able to perform the procedure and the critical steps in the procedure. And based on that, we test it and then we implement it nationwide as a standard of for safety reasons, right? That doesn't become the end all be all of mastery or naturalization or adapting the procedure to a much more complex situation. But I do think, to your point, a novice educator shouldn't be responsible for designing a human factors checklist that is going to change the industry. And it is glacial.
It is, and one of the challenges is there is such pressure on program directors and EMS programs that, this is the amount of time you have.
Mm-hmm.
These are the number of days you have, and you have to get everything done in these number of days. And I'm never surprised. And if you mention, oh, we want to add a week or we want to add a Saturday session, just the upheaval that takes place with that is just, astronomical. But yet we're interested in turning out to employers those minimally competent individuals that the employer doesn't need to take the time to do an extensive, reevaluation or retraining.
Nor do they have the expertise or the tools sometimes to do those evaluations.
That's right, because every agency is totally different. When you're talking about an agency of let's say 500 providers versus one of 25 providers, or then it's too big. You go to the other extreme, that have, 7,000 providers. I always look at the stuff that when LA does it, talks about all of the providers. That's just astronomical.
Mm-hmm.
How do they standardize across all those people?
Right. If every airport tested every flight, every instructor, or every pilot, we wouldn't be able to do it. And I think, I was thinking that maybe somebody who's retired maybe has time to create the tune checklists. Like these are
you need experts. You need experts.
Yeah, you do.
I'm working on history,
Yes. Well, there's so many things that you're unpacking there too, which is, what do we expect of people coming in? Because we tend to blame students for not being prepared, and that's why they're not achieving competency. And the time element, it would be great to have an estimate of the average time it would take to get the minimally prepared paramedic student to competency, so that you could come up with something like that and still have a good system of deliberate practice and feedback and that kind of thing. Because I worry about that.
In the psychomotor portfolio project, we tried first with 7 schools, then 14, then 23, and we had 89 entrustable psychomotor skills,
mm-hmm.
and it was impossible to get 89 individual psychomotor skills to be performed 5 times in a paramedic program.
Yeah,
we couldn't get it done, so it got cut to like 34 was doable. Now, if you can imagine that, there's a difference between 89 procedures versus 34 that you could actually teach and repeat enough that you really thought you really need to do that. So skills like testing for blood sugar became one of those things where you do it once because you need to understand what the steps are, but you don't ever have to repeat it 5 times because you're assuming
Use it all
they're
the
going to
time.
be doing it, and you don't have time to actually
Not a
get
high
that done.
risk. Yeah, not a, yeah. And
So
all of those things need to be graded and all of that other stuff. But yeah, that's a good point. So in this
Is
study, oh, go ahead.
I want to let you finish up the
Yeah.
study because I'm looking at the time and I think it's important we share the rest of it. But this is a topic I think all of us sitting here, and we could drag some more people into this, that we could
For
go on
sure.
for hours and hours.
Yeah, and it is. It's a great topic. For again, this article raises some issues. So they use, as we said, procedural task trainers. This was in a simulation lab. There's something that's in the article though that I think is very important, and I read it twice before it stood out to me. And that is, at no time did these residents get the checklist. So they're performing this skill. They're being evaluated using the checklist, but they're performing the skill with feedback repeatedly. And they're residents, remember, too. So they're not, beginners, are not in medical school. They would be like coming out, and I don't know what the equivalent would be, interns, I guess, for the paramedic level. But they get a baseline assessment. Everybody failed. Spoiler alert. And then, no one achieved mastery, I should say, not everybody failed. And then those that didn't achieve mastery, which was everyone the first time, the mastery level again was 26 out of 27 steps. So real tight. They got a 12-minute video on the procedure and then a 30-minute session of deliberate practice. And Kim, this is where I wanted to ask you to quickly kind of describe, what does deliberate practice look like? We mention it all the time. What is deliberate practice? What does it look like?
Deliberate practice, you should be able to have really clearly defined goals that articulate what the learner should do that is slightly above what they're able to do now. And built into to the deliberate practice is that they would get immediate, actionable feedback about areas that they can, fix, improve related to the task, and then reflection too. They should be able to reflect on what they've done, then repeat the practice again and again, get that immediate feedback. And, so it's sort of a continuous loop. It's almost like a PDSA cycle, right? It's a continuous loop of, first of all, making sure that it's sort of like scaffolding, right? You need to be able to identify where the learners are now and then set the goal a little bit higher again so that they can practice again, ideally until they can't get it wrong. Dave, I don't know if you have anything, or Bill, to add to that.
I agree.
Yeah. So
Agree.
yeah. So I think, thank you, Kim. That's a great, we hear it a lot. And I remember one year at the EMS World PCRF abstracts and poster session, Stephanie Ashford had a great presentation on rapid cycle deliberate practice in pediatrics. We see a lot of stuff, great stuff coming out of that group on rapid cycle deliberate practice in pediatric education. So there's all kinds of forms of it, but it's worth looking up a couple little videos on it, how to do it and how to incorporate it. But I did think it was interesting. They had we do this, hand out the checklist, everybody memorizes it, and then they narrate over a mannequin. They have a meeting over a mannequin. And that's a mistake. In this case, they did not have the checklist. They didn't hand out the checklist to the residents, have them memorize it and have a meeting over a mannequin. They gave the resident a scenario, and the resident ran the procedure according to the scenario, and they evaluated using the checklist. So the checklist was an evaluation tool, not a learning tool. These are residents.
Yeah, or a job aid
Yeah, or
during
a
the
job aid.
procedure. And I do think that's an error. We know today that those you will perform exactly as you practice, right? Perfect performance means perfect practice means you'll get to perfect performance, and they will revert back to their training. And in their training, having a checklist was not part of the training. It was used only to see if they did it right or wrong. So I think that's not current at least not evidence-based practice, and not necessarily going to yield what we want out of a clinician that's going to do a procedure, once in a blue moon, if at all.
Yeah.
I wonder if that, like, just not having that checklist, would that like introduce a lot of extraneous load? Because like after you perform the first time, they're like,
Mhm.
okay, well, you missed, you didn't do this and this and this and this and this. And it's like,
Mhm.
dang.
Yeah.
And they
And
only
the
have,
anxiety, I can't remember 26 items of a checklist
I
2 years after I did a practice, and then I finally have a patient that really had to have it. It
know.
it needs to be, like incorporated into the the human factors. It just goes back to, one of the things we did at Alina when we trained on surgical airways was the checklist was in the plastic Ziploc bag with the device.
That's
So,
awesome.
you open the device, and there's only 4 items on the checklist with a photo, like not a photo, but a drawing,
Mhm.
because you couldn't, things were already assembled by the vehicle service technician, so you don't need to figure out, wait, where does this go
Oh,
compared to this
inline
thing plug
nebs.
in?
Yeah.
Like the inline neb, exactly.
Yes.
You can't depend on that. And then obviously, as you're checking your equipment every day, you're seeing the image, you're seeing the checklist. You don't need to memorize that part.
And
Love it.
Dave, that's why you use slip-on shoes now that you don't have to tie because you don't want that skill anymore. So
Yes. Yes. Average age of the
It's safer.
podcaster on PCRF. Yes. Okay, so they did a 10-week post-test remediation with, again, another cycle of deliberate practice until everyone, so it's all achieve quote unquote mastery, which we usually determine as competency in our checklists, and then a 5-month retention test. There were 56 emergency medicine residents. They were consented. They had written consent. So there's great little research principles in here. But I was really surprised not given access to the checklist at any time. But again, they're residents, so maybe they depend on checklists earlier. But this is a critical skill. A 27-item checklist is a lot for a critical skill, especially if you're going to check them off on all of these things. And what you're seeing here is table 1, which is my preference. I really like the second figure here because it shows a little bit more, but in terms of how the improvement happens. But what you're seeing is each checklist item 1 through 27, baseline testing, the number and the percentage of that got it right. And again, if you get 26 out of 27, it's something like 96.4 or something like that or higher. And then there's the initial post testing with the deliberate practice, and then there's the additional, which is 10 weeks out, and retention testing, which is 5 months out.
I do, for those that can't see the checklist on the screen,
Yeah.
that are just hearing the audio, I think important to note that there are elements of this that we could get into a great debate about whether or not both of us could agree that we agree that uh, as an example, one of the steps is proceduralist dilates CTM, right?
Mm-hmm.
So you're inserting an endotracheal tube. The only the use of capnography is mentioned, right, to
Mm-hmm.
confirm the location. But then the concept of bilateral breath sounds, well, it listens for, and again, if the more vagary there is, the more you go, well, what is listening to bilateral breath sounds? Is that just putting your stethoscope there, one breath, one breath? Is it listening, in 4 places? So it's a weird combination of
Mm-hmm.
some overall steps, and then some fairly hard to agree upon, whether the person was thinking that this was the right step or not. So
Yeah.
dissecting down to CTM, or confirms incision site by palpation with index finger on the CTM, using non-dominant hand while maintaining stabilization,
Yes.
using thumb and middle finger of the non-dominant hand. Wow. Wow.
Yeah. And people agreed on this. There's the one thing I will say is as a researcher, I would have videotaped these and I would have had multiple reviewers. So not that what they did was the person who was conducting the deliberate practice and facilitating was also the rater. So you had a single rater who was also the trainer. And maybe that was a matter of, they decided to do this research in the middle of this. I don't know. I don't know what that was a matter of, but if I really wanted to be a purist researcher, I would have videotaped these and had some double checks with a couple of authors on the scoring to see if there was, some inter-rater reliability on the scoring of their, of the checklist. And 26 out of 27. I mean, I'm looking down this and saying, I don't think I would have used that same method for developing the checklist. I think I would have developed it with that patient safety method of saying which things are absolutely critical and could kill somebody and which things are,
Well,
maybe
and wash his
throwaways.
hands is on here as the fifth step. And so you wash hands, you sterilize the neck, then you don PPE. And I mean,
and I don't know if that's, or is this in order? That's a good point. So if somebody dons PPE first, is that okay? Is that still okay? They did it, or is it out of, what are these in? Which ones are in order? Some things are in order. Obviously, you're not dilating the cricothyroid membrane before you're washing your hands, but but which things actually have to happen in an order is an important thing about a checklist. Again, checklist manifesto, that it is a readable book that'll help you with all these. You should be that critical of checklists, right? We should be that's one of the things we do in EMS too, is we just kind of pick a checklist and say, this is the golden ticket and that's it. If you don't get this, you're out of here. And it's like, well, let's think about this critically. So
what's great about this research paper, and I mean, we're ripping it apart, but and I think but it is super good and ethical to report the tools that you used. And so many articles that we have done podcasts on don't actually show you the checklist that they use. And so I do love that this group was fully transparent and said, this is what it is, and these are each step, and this is how many people completed each step. And that gives us reproducibility in the methods of the study. So I think it's kudos to them for being transparent about this. And at the same time, this was emergency cricothyrotomy, not like let's plan this procedure. And my reaction to does it really matter if I use the thumb and the middle finger of a non-dominant hand if I was able to make the incision correctly? So making the vertical incision is actually the only element there that's like you've got to really make sure you got that and you didn't cut so deep that you don't you're just getting through the skin. So there's some things there that are almost like you need to remember how deep you need to cut instead of it being part of the checklist.
Here's another thing I think I liked about it too, Dave, is if you're out there and let's say Kim's example, you're an EMT instructor and you train on tourniquets, you could repeat this and you could make some improvements and you could publish a little study. If you want to dip your toe into some research, you want to try doing some research. The article has great references in the back. It's a good one to pull up some education theory, to look up deliberate practice. As somebody who is a skills instructor out there, you want to stretch yourself and you want to maybe do a little research. This is a really good one to do. You could pick it and actually repeat it and improve.
I thought it was amazing that they did the retention scores at 5 months. So, I would encourage any instructor in an EMS classroom to do this study and see just how many iterations of deliberate practice it takes. At the same time, the 5 month coming back to 5 months later, that's wow level, because you can only do that with people who you have for that length of time. And really we're in many cases we may not see that student again at some of their levels. So kudos to them. And I'm ultra impressed that 5 months after they do this, they still were able to see that reliability, and particularly about some of these very specific ways in which they wanted this particular skill to be done. So I'm super curious about, these high performing 33 residents, and whether or not that's reproducible in a population of non, in this case, people who've been through a whole lot of education and have a whole lot at stake, and they're in particular in the business of surgery, right?
Yep, exactly. And so the initial post-testing, 59% of them overall, it doesn't show it in this, 59, but you'll see it in the next page, actually. I really like this figure because of the two things, just the visual. You're looking at baseline testing, then you're seeing not just everyone's below the 26 out of 27 line at the top, but you're seeing a huge amount of variability, right? You're getting the low scores of 3 and the high score of 21 and a bunch of them in the middle. That illustrates what we always assume is going to happen. We're going to get a bell-shaped curve. What mastery learning, even though the terminology is confusing, says is no, keep the time element variable and get everybody across the finish line. And that's what you're seeing in the additional post-testing. So deliberate practice toward getting everyone to competency or mastery, whatever term you want to use, is the practice here. And that's what you're seeing. Not only are you seeing everyone get there by additional post-testing, but look at the variability. Well, you're not going to get much variability because everyone's there and there's only 1 point difference, but your variability starts to reduce. And even in the retention scores, even the ones that are lower, we're at the higher end of not just the baseline, but the initial post-testing. And when I look at that initial post-testing score, this is after a cycle of deliberate practice. That's where we tend to be in initial education programs. You see those 1, 2, 3, 4, 5 kind of people hanging out there, and that poor one sitting there who may have a great attitude about becoming an EMT or a paramedic. But they need that little bit of additional deliberate practice and attention to get over into that next group. That's what I see when I look at those dots. Is I think about, we stop a lot of times at that initial post-testing, and then we say, okay, all of you that are below this line, you can't be an EMS person now. And that is kind of, I don't know, it's a little upsetting sometimes, because I think there are people out there that could be EMS, and if we had a little bit of additional testing. Bill?
I agree with the concept that if the program is well designed, has the supportive environment, some extra time or asking them to recycle a semester makes sense. But not everyone is meant to be an EMT or a paramedic, and we need to get away from that concept that everyone does. It's okay to not be an EMT or a paramedic.
It's a tricky concept, though, because there's all kinds of things that can be inserted into that, right? Who is quote unquote meant to be is tricky.
I'm not disagreeing with you.
Yeah.
But there still is, there still is some people that it's just not meant to be their profession. And that's okay. As long as they were given a fair and equitable and had the right environment. You know what I'm saying? All those other pieces are there.
I prefer to say it's not their time. This may not be their time. It may not be the right time. I don't know, Kim, Dave, do you have an opinion on this? But I just feel like it might be, just not be the time for you to think about this. So.
And I think people like to be in the healing arts in some way that makes sense to them. And I do think, if you want to be a radiology tech or a neurosurgeon, these are different skill sets, different activity. So you can, I think, given the right education, self-select into this fits. And then, of course, there's just some realities of the way we do our work right now that in the traditional sense, we really need to make sure they can do. So.
Yeah. And we talk about procedural skills here, but there's other things. We can identify other areas of EMS where we need, where there are critical problems. So look at system problems like differences in distribution of pain management. And is there a deliberate practice paradigm there for actual whole patient treatments rather than just procedural skills? So there's a little bit of discussion about that in a couple of the books that I mentioned, is looking more at overall, like those entrustable professional activities. Overall, can we, evaluate a deliberate practice, a mastery learning paradigm on the treatment of pain, for example, that allows for, all patients to benefit. So there's so many things, but this small study concluded that this simulation-based mastery learning curriculum improved mastery in the simulated environment, but that there was significant 5-month retention testing showed skills decay. And of course, high satisfaction and improved confidence is always shown, but we've seen a couple of studies now that have said, we're very satisfied, we know we can do it. And then when you do retention testing, they can't. So it's, that's always a little tricky. All right. So thank you all for joining us. Next month, we are going to have Ryan Battenhorst on. He is a recent, actually, he is now Dr. Ryan Battenhorst. He just recently completed his doctorate research, and now he's taken it to publication. You may have seen him present at a couple of the conferences in EMS over the last year or two, but now he's got it to publication in the International Journal of Paramedicine. He's going to be here to talk with us about his research called Student Post-Traumatic Stress After Clinical Placement. And that will be on April 24th at 10 a.m. Pacific, noon Central. Don't skip out on that one. That'll be a good one. And then on Monday, April 13th, you can catch Dr. Emily Crow and Dr. Tony Fernandez on the clinical PCRF Journal Club. Don't forget, you can register at PCR at www.prehospitalcare.org, or you can go to our YouTube channel and check us out if you miss us. Thanks for joining us, and we'll see you next month. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.